This is Dr. Jamie Kaufman, and this is Dr. Kaufman's Reflux Hour. Today's topic may be the most important topic that I've covered for a lot of reasons. How do I know if I have silent reflux? As it turns out, gastroenterologists don't believe in silent reflux. In a recent paper that was astounding to me, the San Diego Consensus for Laryngopharyngeal Symptoms and Laryngopharyngeal Reflux Disease in the American Journal of Gastroenterology said that you have to have a GERD, you have to have heartburn, indigestion, esophageal disease, or you have to have abnormal pH study, GI pH study. So the answer to the question is, the first thing is that this group of 28 physicians were unable to do a literature search. So not a single one of my papers or those of my basic science compatriots is included. And many of the questions that are raised are actually answered by these papers. For example, pH documented refluxers, about 4/5 of them don't have a normal esophageal examination. So examination of the esophagus is not how you make the diagnosis of laryngopharyngeal reflux. And as you know, I'm not using that term anymore. We're now calling it respiratory reflux because laryngopharyngeal reflux is too limited. Now, how do you know if you have silent reflux? You don't have heartburn, you don't have indigestion, you don't wake up in the middle of the night. Here are some ones that will pretty well, for sure. If you eat dinner at 8 o'clock at night and it's your major refueling meal of the day, and maybe you have a cocktail or glass of wine, and go to sleep at 10, 2 hours later, you have virtually 100% chance of refluxing all night, whether you have symptoms during the night or during the day. But the symptoms during the day are sensation of a lump in the throat, difficulty swallowing, hoarseness, too much postnasal drip, chronic throat clearing, shortness of breath. It goes on and on and on because all of the respiratory system can be affected. The arrogance, the combination of ignorance and arrogance is the worst thing you could possibly see in a physician. These are the kind of physicians that take people like you who have serious reflux and tell you that it's in your head, you need to go see a psychiatrist. That's malpractice in my opinion. So what we're dealing with now is a complete schism. And this particular paper is the most regressive paper of the last 50 years. And regressive means, I looked it up, regressive. A return to a former, less developed state. So in my opinion, this paper could have been written exactly as it's been written 50 years ago with no changes whatsoever. This paper is a perfect 1985 paper. So why has there been no progress in the last 50 years? And the answer is gastroenterologists. The gastroenterologists have a heartburn business model. They stick scopes down people, and then they make a lot of money with a facility fee. They own the surgery center and a professional fee, and they put you on proton pump inhibitors. So I want to just make two more comments about this, and then I want to move on. Proton pump inhibitors cure 0% of people. One of the things that they say in their paper is, if you go on proton pump inhibitors and you don't get better in 3 months, then you can't have a respiratory reflux. Nothing could be further than the truth. The majority of the patients that come to me have had proton pump inhibitors, usually for years, with multiple proton pump inhibitors, and so on. So PPIs cure no one. They're an acid reducer. You see, I'm a little excited here today. Reflux is about pepsin. So when you reflux, pepsin comes up and attaches to your tissue. How long does it stay? Maybe they do their reflux studies during the week, and Saturday nights tonight you go out and tie one on, have 2 cocktails and a big steak and so on. and you reflux like crazy Saturday night, and that is enough to set you back 2 weeks. One bad night, so they don't test Saturday night, do they? Furthermore, the kind of technology that's available is no good. Okay, so the kind of technology that GIs are using, I put a high quality pH meter in the throat, and we have data from almost 30,000 people. And we know they have reflux. We've proved they have reflux. And we proved that all these symptoms are reflux related. And the proof in the pudding is that we have been able to resolve them. That's right, people get better. And when it comes down to it, the only treatment that works is diet and lifestyle. And it's not as simple as you think. So I think next week I'm going to talk about how do you cure acid reflux next month. So let's go back and talk about how do I know if I have silent reflux. So if you're eating very close to bed, you have silent reflux. If you believe in having a nightcap, alcohol is a second biggest reflux factor. If you have a nightcap before you go to bed, you have silent reflux. If you wake up in the middle of the night coughing and gasping for air like a fish out of water, you have maybe not that silent reflux. If you have a constellation of symptoms, you have globus, by the way, they did not include globus, difficulty swallowing, and a sensation of a lump in the throat, globus and dysphagia. Meanwhile, we've studied it, not published, and will be published in my book on respiratory reflux. The upper esophageal sphincter is here, and with reflux, it misbehaves, and one of the most common problems is closure of the valve in the middle of the swallow. When you ask people who have difficulty swallowing, they point right there. And indeed, all of those globus and dysphagia patients get well when the reflux gets well. We did manometry, pharyngeal UES manometry for years. So, globus and dysphagia. If you have difficulty swallowing, it's here. If you have a sense of a lump in the throat, it's here. Now, here's a tricky one. It's not 100%. You say, oh, you have globus. It's driving me crazy. I've had it. I have a lump. It feels like this thing there. And how do you know? How do I know? It's probably upper esophageal sphincter. I asked the question, do you notice it when you're actually eating? And the answer no is written down. So if you have globus, except when you're actually eating, you have some, with or without dysphagia, you have respiratory reflux. Almost all patients with respiratory reflux have normal esophageal examinations, and reflux studies are irrelevant. If they're abnormal, you got reflux. If they're normal, you still got reflux. So what I'm saying to you is, very important for you to understand this. The state of the art right now is 1985. All of these gastroenterologists are like people who believe the world is flat. And all of the flattists have got together, in some cases, to get rid of competition, for example, transnasal esophagoscopy, that would have basically made sedated endoscopy go away. If I ever get into Medicare, I'm going to say, wait a minute, why don't we have no facility fee like it used to be, and a good maybe $700 for a TNE, and then the people in offices can do them, even primary care physicians can do them, and we don't need you to be put to sleep by a gastroenterologist. And as a matter of fact, do you need a colonoscopy? If you have no history of trouble, and you do a Cologuard, which is a poop test where they look for abnormal DNA, then you don't need a colonoscopy either. So the whole concept of upper endoscopy maybe not so important anymore. So if you look at constellations, okay, well, someone has chronic cough. It started after a respiratory infection. They've been coughing like crazy, but they cough when they lie down at night. They cough when they bend over. They cough after they eat. The cough is wet, meaning it's productive. It has mucus in it. These things are characteristic of reflux-related cough. And obviously smokers, it gets doubled. So I'm talking here about lifetime non-smokers, but even smokers are made considerably worse by reflux. So what other symptoms are sort of ringers? I recently did a study of people who are doing consults with me. And let me digress and say, I never wanted to leave New York and I never wanted to stop practicing medicine. But COVID shut me down. I've been sick. I've had long COVID ever since. And I'm now doing virtual consultations where I get to see my consultees or patients eyeball to eyeball for a half hour. We never have a problem making a diagnosis. Furthermore, most of these people sound like their vocal cords are quite swollen. So we think swollen is what. And by the way, for the people who, GIs, you want a test, I'm going to give you a test. You can have your otolaryngologist take a little tiny bit of tissue from the back of the larynx and stain it for pepsin. Foolproof diagnostic gold standard. Pepsin, not acid, pepsin. Inflammation, yes, pepsin as well, causing the inflammation. So, if you just add up symptoms, let's talk about too much throat mucus, chronic throat clearing, postnasal drip. If it's thin, it doesn't get on your vocal cords and can be related to allergies. If it's thick, it's reflux. Okay? There aren't 15 other causes of that. Air pollution doesn't cause thick mucus. Reflux causes thick mucus. Contributive factors may be things like air pollution and secondhand smoking. But the thick mucus is reflux. The reflux of the person who's complaining of a postnasal drip. So we have postnasal drip. Number one symptom, 88% of my consultees. And then we have hoarseness. High number of people complain of voice problems. And then, believe it or not, the third most common symptom in my group, people who come to me, is shortness of breath. And so without further ado, there are three types of shortness of breath, at least I know. There may be more. The first is difficulty with exercise. You go up 2 flights of stairs and you're huffing and puffing, and you shouldn't be huffing and puffing. That can be reflux related with normal pulmonary functions and a normal chest x-ray. The second type is related to airway, and both choking episodes like laryngospasm and asthma are examples where the airway can be compromised. And I'd like to introduce this, and I'm going to continue to reintroduce it. If you have difficulty or discomfort taking a full breath in my opinion, that is pathognomonic of respiratory reflux. It's vaguely mediated, but I don't know if it's because there's mucus down there and you feel you're going to cough or what the problem is, but it seems to be that this is the single most common type of shortness of breath. So when somebody says shortness of breath, I ask them if they have number 1, number 2, number 3, all of them, 2 of them. And inability to take a full breath in or discomfort is the number 1 shortness of breath symptom in patients with respiratory reflux. How do I know? Let's keep going. So we have postnasal drip, we've got coughing or reflux symptoms when you lie down, waking up in the morning with more hoarseness, more mucus, more throat clearing, cough. We mentioned the characteristics that are criteria after meals, lying down in the middle of the night. And so if you have a constellation of all of these symptoms, there's not another diagnosis. These are 28 doctors who wrote this piece of medical bullcrap. They don't account for the symptoms of people just because they can't measure it. Okay, they don't. Maybe when you put a tube down, some people just don't reflux very much. It stimulates the esophagus. Who knows? I did pH testing for a long time with a pH device right here, and we found most people who had reflux, clinically had reflux on pH monitoring, but not necessarily. They may have been not wanting to eat that day. They may have been upright, watching movies all night. We have no reason to believe that the tests that we have are a gold standard. And so this is when the ignorance and the arrogance gets together, because they say you don't have respiratory reflux or LPR unless you have esophageal disease, esophageal symptoms, and abnormal pH test, GI type, impedance, or Bravo. So all of it's crap. Okay? It is my hope that the gastroenterologists respond to me. It's interesting that they did not quote any of the papers, all of the cell biology, everything. It's about pepsin. Okay? No amount of proton pump inhibitors. You could take 80 Nexiums a day, and that would not make your reflux go away. So you have to stop the reflux completely for a reasonable period of time. We'll talk about that next week. And that includes more than just diet and what time you eat dinner. It's a detox program. There are 8 elements to that. And I'll talk about that next month. So what I'm saying to you is that the constellation of symptoms, and as simple as I have postnasal drip, globus, and sleep apnea. Well, I think snoring and sleep apnea are caused by long-standing, perhaps decades of respiratory reflux. Why? When I was young, there was no such thing. By the way, there was only one obese man. All of these diseases have come since changing American diet started in 1965, when we really sort of discovered fast food. 30% of the American diet is fast food. And of course, the $1 trillion elephant in the room with regard to all of our chronic diseases is diet. So why aren't we addressing this as physicians, and why aren't we training people to actually address reflux? So you could have a college kid who is trained to be a reflux and a diet and lifestyle coach. So we don't need the doctor to spend a half hour. There are a lot of ways to create integrated aerodigestive medicine, and that's the key. So the problem is the otolaryngologists look at this all day, the pulmonologists look at the esophagus and stomach, and the poor pulmonologists, they don't look at anything because if they think the patient has reflux, they send the patient to the GI. The GI doesn't know or says it's not reflux. So what I'm saying to you is, you're the doctor. The world is not flat. All of the flattest, to a man or a woman, will not recognize respiratory reflux based upon the symptoms. Now, they also talk about the examination. In my book, I decided to simplify things, since here's the problem with otolaryngologists. They don't know what normal looks like. Reflux is so ubiquitous, they don't know what normal looks like. So I'm going to tell you right now, supine nocturnal respiratory reflux, that's what we're talking about, snore, S-N-O-R-R. If the back of the larynx, the postcricoid area, is swollen enough that it's touching the back wall of the throat, that patient has supine nocturnal respiratory reflux. It's pathognomonic, or they get CT scans and biopsies, reflux. So what I'm saying to you is that, how do you know if you have silent reflux? It's based upon educating yourself. I strongly recommend you use my blog. I've written it for people who do consultations. You can type in hiatal hernia and it'll pop up with information about that. And certainly you need to read about pepsin. So the whole deal in getting rid of reflux is getting rid of pepsin. And acid is not where it's at. So I can't say which symptoms, as you see, I'm floundering, which symptoms are related to silent reflux, and the answer is all of them except heartburn and indigestion. So here comes the big one. In my experience, for every patient who's a GI patient who meets their criteria with heartburn, indigestion, abnormal studies, meaning esophageal exam and pH studies, for every one of those, there are 10 people who have respiratory reflux who don't fit their ridiculous criteria. It's so presumptuous to assume that the gold standard is, listen to this, you take PPIs for 3 months and if it doesn't get well, it can't be reflux. Okay? So that totally misunderstands the pepsin thing. Now, I apologize if today was a little less structured and a little more rambling, because I just got this paper, and when I read it, I was dumbfounded. And I can tell you this is a 1985 paper, and one of the reasons there's been no progress is because all of the work that we've done on laryngopharyngeal reflux has been ignored by the GI community. I suggest you go to PubMed and type in Kaufman, Koufmanj, and Johnston, N, and you'll find the cell biology. And by the way, on my blog article on alkaline water, it's a man looks like he's made out of water. As you get to the end of that, you see a biopsy, and a normal biopsy technique is on the left, and on the right, a stain for pepsin. There's pepsin everywhere. It's on the surface, it's in the tissue, it's intracellular, it's extracellular. So all you people who have hoarseness and all this other stuff, that's what you look like. So pepsin, and PPIs, I stopped using more than a decade ago. That's been a rant, and I'm sorry. This is very distressing. And by the way, I only know one name on this. So who knows what the experts are? And it's international. 28 dummies. So let's go to questions. The first question is actually specific. The question is from Wendy, and she asked, do you definitely need endoscopy if you have reflux? She has some symptoms that suggest she may have esophageal reflux. Worried that it might be gastritis. Okay, so gastroenterologists biopsy the stomach almost routinely, and the reason is it keeps the pathologist in business. Virtually 100% of people have mild gastritis on biopsy. This is not a symptom of gastritis, and furthermore, that's not the question. The question is, do I need an endoscopy? And the answer is, you need an endoscopy once, probably, not sure really, but transnasal esophagoscopy is how it should be done. And that's done in the office with an ultra-thin. It's a better quality examination, more accurate biopsies than EGD putting you to sleep. By the way, since 1975, you'll be absolutely stunned how many people have died in these little surgery centers having their endoscopies with GIs. It's bigger than the number of people who lost their lives in the Vietnam War, 55,000. So the answer is, we need to get into Medicare, explain we have an alternative. There should be no facility fee. We don't want to have it done in a special facility. We want the doctor to do it. We want to train the physician assistant to do it. We want the primary care to have an integrated air digestive medicine team. So the answer is, you probably need an endoscopy once. It doesn't matter what your age is. I mean, if you're 80, probably doesn't matter, and if you're 20, it probably doesn't matter either. The earliest I've ever seen Barrett's is age 28. Can LPR cause strictures in the larynx and in the postlaryngeal region? This is really prize-winning respiratory reflux. You need to never again eat late, never again drink alcohol, continue to take medicine. We'll talk about that, famotidine. Continue to use analginate, and it goes on forever. So in my practice, I never counted them up, but I estimate that I have between 700 and 800 patients with Barrett's esophagus. In the old days, we said to people, well, you have 1% chance per year of getting cancer. So I want you to know that my 800 patients, not a single one got, some of them have long-standing follow, not a single one got cancer, and some of them, the Barrett's went away. So it's reflux that causes cancer. It's not Barrett's. And if you look in Barrett's, nobody's done this. In the book, I'll show an area of Barrett's, and there it is, stained for pepsin, 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 pepsin. Pepsin is the enemy. Acid makes it work. That's all there is to it. That's why the pepsin in your throat, you drink a Coca-Cola, and you say, well, that doesn't get on my vocal cords. Well, sure it does. All that stuff ends up, the mucus up here, and the mucus down here, and the mucus that gets swallowed, the mucus, all of it's the same. And it may get the vocal cords less than it gets other areas, but certainly there's good reason to believe that dietary acid activates pepsin. So you had one reflux episode, and then your diet keeps it going for the next year. The stricture problem needs, if you really want to know the truth, you need to do everything. If you were my patient and you really had that stricture, I would have fundoplication surgery by the best surgeon as well. And then I would use radial dilations with a CO2 laser and radial cuts with a CO2 laser and then dilation. And if it comes back, then you have to wonder whether the reflux is under control. And those people will all have abnormal pH studies, but not necessarily GI type. My dry cough is my only symptom. Never had croup. What is it? Jeanette. I don't want to talk about neurogenic cough much, but I shall. Most people have had infection of the vagus nerve at some time in their life. Actually, it's 40%. And what happens is the nerve gets sick, and it causes reflux, causes cough, and it causes voice problems. Oh, I had the flu, and 3 months later, I've got all this stuff. So, meanwhile, there's a subgroup of people who have dry cough. Generally, wet cough is reflux, dry cough is not. Bending over, if you look at the book, The Chronic Cough Enigma, you'll find answers there. And also, on the blog, there's specifically an article on dry cough and neurogenic treatment. So some people have neurogenic dry cough, not many. If you look at my consults that I've done over the past year, I think I've only seen 3 patients that I thought really had neurogenic problems, maybe 5 that needed treatment. So usually it's reflux, reflux, reflux. Does respiratory reflux cause dry eyes? It's the other way around. Turns out that a lot of people have Sjogren's syndrome. I don't remember the number, but it's like 3% of the population, maybe 6%. And what that means is you have autoantibodies to your salivary glands, and so you don't have as much saliva. That's bad for reflux because everyone has some reflux, and usually it's the swallowing of the saliva that also has bicarb that gets the pH back up to a normal pH with a couple of swallows. So generally speaking, people who have Sjogren's syndrome or have had head and neck radiation all pretty much have reflux, and reflux with a radiation of mediastinum as well. So dry eyes are a symptom of dryness, which makes reflux worse, and it's probably related to a cause. I'm not going to answer this cough, but this is the problem. I have a neurogenic cough. I've seen ENT pulmonologists, gastroenterologists, and neurologists. None will prescribe amitriptyline and gabapentin. By the way, on my blog, there's a post. Just type in neurogenic, and you can literally take a PDF to your doctor. Work with your primary care. If you have a good primary care who makes eye contact with you, who listens when you talk, you listen when they talk, you can easily convince them and teach them about neurogenic cough and give it a trial. The doses are as small as possible, and they're escalated in such a way that side effects are very uncommon. But most of you do not have neurogenic problems. So a question here, I get this question every week, every When is the new LPR medicine, fostemprevir, expected? So you know I'm involved in a company making a new product, and it is called fostemprevir, and it prevents pepsin from binding, and it takes care of pepsin. It will be effective as a pill. I have no question about it. But its real use will be as a spray, or even in your atomizer, where your whole respiratory tract is basically freed of pepsin. Remember, pepsin is the enemy. So the answer is the clinical trials, human clinical trials, will start before January. And once that happens, and we start to get some data back, or when we get data back, I think there'll be a lot of interest among big pharma competing to have this. And it'll be very helpful. But it won't make reflux go away. It'll just help neutralize the effects of pepsin, which is pretty much where it's at. People are asking about alkaline water, and does a Costco alkaline water pH 5 contain phosphates? I've said to you before, Essentia, which is everywhere, I think made by Coca-Cola, pH 9.5, has a phosphate of some kind in it, phosphoric, and patients complain of throat burn. So I would recommend that you just look on the label. They'll tell you what's in there, okay? And if it says phosphoric, whatever, then it's not so good. Personally, I don't know the answer about Trader Joe's water. I got a lot of questions about, I did the detox, and I still have reflux. And what you'll find out is diet is one of 8 steps in a detox. And you'll be surprised that having a good probiotic is also a recommendation. I've written an interesting article on the relationship between gut health and reflux, and we know gut health has to be disturbed because the normal flora must be wiped out in the esophagus before you get candida, which is fungus growing. So we recommend it. Not only that, a lot of people who take a probiotic, a good probiotic, say it helps their reflux. The one that I currently take is Garden of Life for Men and Women, 90 billion on Amazon. I don't know if it's better or not. I don't support anything. I don't get any money back from any product. I've been diagnosed with a sliding hiatal hernia. Why only 2 cms? PPIs haven't worked. So it's the same question all over again. 2 centimeter hiatal hernia. Read the article on hiatal hernia. It's not clinically significant, and PPIs haven't worked. PPIs are not how you treat reflux. Okay? 0% of people get well on PPIs alone. 0. That's a very loud number. So, one last question. How much alkaline water should I drink a day? I recommend if you've got significant reflux, you drink it all the time. But how much do you need? This is alkaline water, 9.5. I have the Sierra water pitcher. When I get up in the morning and make tea, I try to finish my tea with one of those. Rehydrating in the morning for me is particularly important. If I don't feel well in the afternoon. So I try to drink, I guess those are 24 ounces. I try to drink 4 of those a day minimum, and some days more, which means a lot of trips to the bathroom to wee during the evening. So listen, I've been as forthright as I can be. This has been an excitable topic, especially since the silent reflux literally doesn't exist in the minds of the 28 physicians who wrote the San Diego Consensus for Laryngopharyngeal Symptoms and Laryngopharyngeal Reflux, disease. So they're saying you can have all those symptoms without having any disease and without having reflux. And good luck with that. Bye.